Welcome to our program on hospital planning for mass casualty incident surges. Chuck Lane, an instructor for CDP, will be addressing our content today.
I definitely want to start this by saying to every single one of you who are out there dealing with, I think 2020 in general right now, all the different things that have going on, regardless of what your background is. Thank you for your service to the country. Thank you for the services that you're providing to the community. I hope you're all staying safe and staying well, and hope you enjoy this webinar this morning. Hopefully I can give you some insights on some things, or maybe expand on some things that you already know, and we'll get going with this. So my background specifically is healthcare emergency management. I come from about 14 years in the healthcare field, running a large hospital system here in the Memphis, Tennessee area where I'm based out of. Done a lot of different things with hazardous materials decon operations. We spun up a team when I worked there that was basically called a disaster assistance response team. So each different hospital, a lot of focus on mass casualty surge planning and kind of these no notice to low notice incidents that we're going to talk about today. Now, even though we're talking about natural disasters, I'm going to supplement parts of this with some other no notice incidents kind of stuff, with the Las Vegas article being a big piece of this, to kind of share some best practices and share some insights for how quickly this can occur, how quickly patients can arrive, and some of those little things that we can do to kind of make this a little bit more manageable for us at our hospitals. So the objectives for this, we're going to identify the different natural disasters which do impact hospital surge, kind of what things are relevant to your area. We'll talk about the HVA a little bit. And a good bit of this is going to be kind of around how to estimate casualty numbers. There's no hard and fast rule with this, but trying to understand how many people are in our community, how many people might be impacted, and then how many of those people are going to come see us at the hospital. How to estimate casualty acuity levels. We'll talk a little bit about disaster triage. What types of injuries are common to the different types of disasters, so we kind of know who are we going to need to pull when, who's going to be available, what type of resources and supplies would we need for what's relevant to our area, types of physicians that we're going to need for those same types of injuries, and then surgical needs, how often those appear, what type of resources we need, all that good stuff. So the thing to understand and kind of frame this webinar out when we're talking about natural disasters and hospital surge, and we've got two good examples here. I hate to say good examples, but dramatic examples is maybe a better term. The left is Biloxi after Hurricane Katrina, and then on the right is the Haiti earthquake in 2010. So obviously, very complex disasters occurring over large areas, affecting a very large portion of the population. And even though these are extremes of our natural disasters, the lessons we learned, along with examples that have been provided by healthcare providers, emergency response personnel, they've given us a lot of valuable data for how we plan at hospitals and how we kind of expect things to occur and flow during a mass casualty incident. The one thing that I really want you to keep in mind when talking about natural disasters too, and this has been a big push past several years or so, but natural disasters are really just natural events, right? These things occur frequently throughout the world and throughout the history of our world. That, we have hurricanes, we have flooding, we have tornadoes, we have earthquakes, all these different things. They're not really a natural disaster until that natural event meets that human population. And that's where we have to really look at what is the population around us, who is getting impacted, and how do we plan for this natural event's impact on a human population, which then becomes a disaster. And the way we do that is by developing a hazard vulnerability analysis. Excuse me, I can't talk this morning. The HVA is critical to all these other planning methods. If you don't have a good HVA, you don't know what can impact your community, who is in your community, then everything else is kind of moot. You're already off to a bad start. So when you run down the list of an HVA, there's all these different disasters that you can have. Hurricane, tornado, severe thunderstorm, snowfall, blizzard, ice storm, earthquake, tidal wave, so forth, so on, all the way down to volcano and epidemic. So when we're considering these things, not only do we have to just say, oh, okay, well, I know we're not going to have a hurricane in the middle of the country, but we could have a tornado. We could have a severe thunderstorm. Maybe we have an earthquake. When these things occur, we're not just looking at saying, okay, well, we know an earthquake would have major damage to the community. What does that damage look like? Do you have a lot of high rises in your area? Do you have a large vulnerable population? Do you have a lot of elderly people? Do you have a large community that maybe is non-English speaking or English isn't their first language? All these things kind of blend into your impact so that you know once these patients start arriving to the hospital, maybe what are some of the other challenges that you're going to face. So the way we start estimating casualties when we figure out who's coming in is what we use is called the dual wave phenomenon. Now this is the first wave, which is going to be minor care, you're walking wounded. The second wave, a little bit more seriously injured people. And then obviously our pediatric populations can range anywhere from 10 to 20% of the total number of casualties. But when we're looking at that and trying to figure out what we're going to do with that information, keep in mind that this is directly affected by geographical factors, your population density. Are you in a more metro area? Or are you in a rural area where things are more spread out? And you're probably not going to have a large group of people impacted in the same small area. So if you're in a metro area, major city, and you have an earthquake or a tornado, you're probably going to generate a lot more patients very quickly than obviously you would in a sparsely populated rural community. For those of you that may be familiar with the 15 until 50 model that's come out of California, it's a very good way of looking at mass casualty incident surge. And basically just focuses on 15 minutes until you get 50 patients. And that number is just kind of based on being out of a metro area that they're going to show up fairly quickly, depending on their distance from the scene. But this says, arriving within the first 15 to 30 minutes. That first wave is generally going to be transported by personal vehicle, whether it's them driving themselves away from a scene, fleeing on foot, or in the case of the Las Vegas shooting, where a lot of people were just put into personal vehicles and then driven to the hospital. So there's this rapid extraction from the incident scene, going to seek emergency medical care, and you don't have that delay of EMS going to the scene, packaging up a patient, triaging, and then transporting them to the facility. So that second wave is generally going to include the higher acuity patients. It's not always true because of the personal vehicle kind of transfers, but generally speaking, in a natural disaster, the second wave is going to be your higher acuity patients that are coming in from EMS. The pediatric population, where it's important to kind of take this into account, is, I'll give you a personal example with us. The system that I worked in, we had a large pediatric hospital that serviced the community. There was another healthcare system that had a pediatric hospital. So there tended to be that day-to-day mindset of, they'll go to that facility because that's pediatric. And obviously we know in a natural disaster, in a major event, pediatric patients are going to go the same way everybody else does, generally to the closest facility. So make sure you're not forgetting about your pediatric patients in your planning. Now, total expected casualties. The algorithm that we use for kind of planning for this is basically our total expected casualties equals the number of casualties that arrive in the first hour times 2. And that's just based on the fact that most of, or about 50% of, I should say, the acute care group arrives within that first hour window. Okay, so those people needing the highest level of care are going to show up generally the quickest. And then we get into that 90-minute to 4-hour window that the other 50% is going to arrive. So if we have 100 people show up in the first hour, we generally expect about 200 patients within that first 4-hour window. Doesn't mean we won't get more later, but that'll be our surge window, so to speak. So this again is where your HVA or your community risk assessment can help a lot. You have to think about maybe what's going on during the time of day or time of year. If you're in an area that has a lot of events, so again, I go back to what I know here in Memphis, we have a lot of community events. There's races, there's Memphis in May, which is Music Fest, Barbecue Fest, all these different things that normally occur. if we were to have an earthquake or a tornado during one of those events, the amount of people in our community that would be there, be in a small area, and then immediately probably be injured and need medical attention grows exponentially from our just normal day-to-day capacity of the city. So keep that in mind and think about, okay, what's the worst case scenario? What happens if we're hosting the playoffs or we're having our big festival and our natural disaster occurs? How many people are we going to get? This also is, thinking about time of day. How many people might be injured in a tornado that hits the middle of the city, or an earthquake that hits the middle of the city during the day, Monday through Friday, 8 to 5, versus Sunday at 3 a.m. So those are things to make sure you're calculating and looking at. Are people at work? Do you have events going on? What happens in the middle of the night? And then think about that with your staffing ratios. So if it is 3 a.m. in the middle of the night and this happens, you're probably going to have less patients, but you also have less staff, nurses, physicians, support staff. So those are things to consider as well. Now we're talking about acuity levels and disaster triage and all this. We're really just trying to focus in on who needs care the quickest, right? So how do we identify as rapidly as possible who needs to be taken care of, who needs access to higher levels of care, whether it's surgery, intensive care, just rapid interventions that are life-saving. That's what we're trying to identify first. And the traditional triage methods that we utilize, unfortunately, just don't work here, right? When we get too focused on the normal questions we ask every single day to every patient in the ED when they come in, obviously it's just not going to work in a disaster scenario. So what we have to do is implement a disaster triage system. Now, whatever you use, whether that's SALT, whether it's START, the key to that is training and practice. We have to be able to immediately identify this is not a normal event. This is a disaster scenario. We have to immediately spin up and move into a disaster triage mindset. If you don't train and you don't practice for that, nobody's going to be able to do it. We see students struggle with it all the time, even after years and years of experience working in the field, working in the ED, when trying to use disaster triage and do that quick 15, 20-second analysis of a patient, they sometimes struggle to move forward with that. So you have to implement your training. You have to have your process outlined in your plan, determine what you're going to use, which method, SALT or START, and then practice it. How often do you train on it? We used to do something called Triage Tuesday, where EMS would bring people in with a triage tag. You would do a quick assessment and then move the patient along. So however you do it, whatever you identify as a best practice, is definitely something that you need to do when you're implementing a triage system. So for those of you who may be very familiar with disaster triage, this will look very familiar. If you're not familiar with disaster triage, this is kind of the breakdown of what we're usually going to see in a natural disaster. So about 20% of our patients are going to be immediate or emergent acuity. We'll call them red patients often. And these are your emergent severe injuries. So you can generally expect, based on the statistics, about 80% of these patients to show up within the first hour with life-threatening injuries. So it's very important to be able to rapidly assemble your staff, your supplies, and your equipment within that 15 to 30 minutes of notification so you can get your supplies out there and get things rolling. I'll share this with you from this Las Vegas document. I thought this was really interesting. The initial patients that arrived to Sunrise Hospital, where the study took place, had 24 EMS transports and 188 private vehicle transports. And the majority of the higher acuity patients did come in via private vehicle in this situation. So again, kind of expect that some of these patients, some of that 80%, is going to show up within that first hour via private vehicle. 10% of those required immediate OR procedures, so identifying them very rapidly, getting them to surgery is paramount. And then there's a lot of different staff that you'll utilize to support this. ED trauma, critical care nurses, paramedics, your respiratory therapists, your radiology techs, your phlebotomists, blood bank, lab techs, even behavioral health, OR, ICU staff, and pharmacists. All these different groups are going to be needed very rapidly right from the beginning. So make sure you have plans for how to identify them and bring them in. Yellow tag patients are our next 30%, and we call them urgent or delayed generally. Yellow tag patients are generally referred to as delayed. And this is going to be that 50% generally that's brought in by EMS within that first hour to 90 minutes. And this group, while they need higher levels of care and they do need more attention, that doesn't necessarily mean that they need to immediately go back. They can wait for just a little bit so they can tolerate that delay. Your other 50% is your non-urgent, your walking wounded, minimal, minor, whatever you want to call them. These are people that show up generally, again, that first probably 15 to 30 minutes, but within the hour, they show up, they need some sort of care. They may have been injured leaving the scene. They may not realize how injured they were by the time they got to the hospital, but these are people that we can identify and then treat. The key to this, and one of the things that we see very often in drills and exercises, but also see it in real events as well, is that people that get identified as minor or green or walking wounded, they're kind of set to the side and sometimes forgotten about. So you can't do that. You have to make sure that you're going and consistently checking on them, consistently making sure that nobody is deteriorating in their condition, that nothing's gotten worse. Just make sure you're going over there talking to them. So assign somebody to each of these areas, however you do this, whether it's an indoor area where you take the different patients, if you have tarps or tents set out to identify red, yellow, green, black, make sure that you are staging somebody there that can continuously check on those patients and do a little bit more thorough evaluation as we go. Now, the last one is our expired or expectant patients. And these are the patients that when we're dealing with a mass casualty surge, they are not going to experience care, for lack of a better term. So we're still going to provide palliative care, but we're not going to necessarily provide any life-saving treatments, right? So maybe that's resources, maybe the injury is too grievous that we just can't manage things, so we're going to move them along. One of the things too with this that I thought was interesting, in the Vegas shooting, it was just a kind of a line in the document, but I said consider bringing deceased patients brought in by loved ones back as expectant rather than just black tagging them, and that is a consideration to have kind of a morbid waiting area to receive those patients. So hang on, Tom, I see you got your hand raised. Tom, did that work? Can you ask a question or? Okay. Tom, you may have to type in the question and we get to it at the end.
Tom, if you'll type it in the chat box or send me a private chat, I'll get it to Chuck.
All right. So moving to this next piece and talking about the type of injuries that we can expect to see by the event. And this just really talks about, some of the different ones that we can see and kind of expect based on what's relevant for us. So again, if you're looking at your HVA and you have tornado, then obviously blunt trauma, penetrating trauma, crush injuries, and then infected or contaminated wounds could potentially be an issue, whether a patient stays longer in the hospital or if they're rescued after a day or two of being injured, you could experience that. Hurricane, you pretty much cover all of them. You could have respiratory issues, gastrointestinal issues, which we'll talk about in a minute, that are very, common symptoms of hydrologic disasters, so water-based. But submersion industries, from near drowning, people trying to self-rescue out of an area that's flooding may experience submersion industries, so you need to count on that. Earthquakes, again, your trauma, blunt, penetrating, burns could be one. I think that's often overlooked in some of these, and I would almost add it potentially into tornado as well. When you have damage and you have things that gas lines get disrupted, you may have house fires because of the damage, commercial fires, whatever the case may be. You may still see burns, you just won't see them maybe as widely presented as you would in something like a wildfire. So these are just kind of a good layout and a good example of some things that you can expect. You're going to have head and neck injuries, you're going to have injuries to the extremities, thoracic injuries, but then you also have a lot of minor and worried well injuries. I'll kind of get to my story about one of the tornado responses I worked before, and we had a lot of the minor and worried well show up. So gastrointestinal injuries or illness I want to talk about for a minute. With hydrologic disasters or with hurricanes, flooding, you can have contaminated food, you can have contaminated water sources. A lot of people, whether they're displaced, not so much in shelters, but if they're displaced for an extended period of time, you can have poor hygiene. Maybe there's not access to clean water, so there's sanitation issues, sewage issues. You can have vector-borne diseases, staph, E. coli, all these different things that pop up from this and that can cause gastrointestinal illness. So you may see a rise in that when you're treating patients in the days after a natural disaster. Respiratory infections are another one, and I think this is kind of on everybody's mind right now, probably due to COVID. What happens if we have a natural disaster and then we start putting people in shelters? TB was a concern in the past, but you can have viral and bacterial infections become respiratory infections and then spread very quickly through a shelter. So those are things you have to kind of plan for if you're even in the hospital cohorting patients or anything of that nature. So when we talk about surgical needs, and you can kind of see the breakdowns of, the life-saving, hemorrhage control, craniotomy, that's 10% of our red tag casualties. So those are the ones that are going to need rapid identification, rapid access to surgery, rapid access to higher levels of care. We're going to need supplies, we're going to need surgeons, we're going to need a care team very quickly. So understanding kind of what you would see if you go back to that previous slide and think about, okay, here's the type of injuries we can reasonably expect for the area we're in, for the hazards we've identified. Now, here's the type of surgeries that we may see and we may need. So open fractures, eye injuries, urgent neurosurgeries, chest surgeries, oral maxillofacial surgeries, and then burns. And they kind of go down the list of these, but the key takeaway with this is that typically in a natural disaster, only about 10% of your red tag casualties require that stat emergency life-saving surgeries. Most of your casualties are going to be somewhere below that. They may need surgery eventually, but we can stabilize them right now, or a lot of the patients are just going to need some care and they can be sent home. One of the things that you do have to consider with those is that a significant number of these patients, especially the higher acuity patients, may require one or more surgeries, more surgical interventions. So you can consider bundling the surgeries or working with the care team to see how they want to address that. Don't forget as well, I talk about this a lot with teaching kind of the infection prevention practices and some of the other stuff we're all worried about right now, is don't forget your EVS team when you're talking about surgeries and needing this, because you need to be able to turn those ORs over very quickly, or maybe possibly prep areas as alternate care sites for other types of surgeries. You may not be working in the same conditions you normally would, so think about what that looks like and then what's achievable. But don't forget your EVS teams when you're talking about a lot of this stuff. Now, with physicians, we've kind of building on this, right? We've talked about the types of injuries by disaster. We've talked about types of surgeries we may see. Now we've got a list of all the different surgeons we may need, as well as some of the other just different physicians, pulmonary, infectious disease, pediatrics, OBGYN, behavioral health practitioners. You'll notice that pediatric, OBGYN, and behavioral health are needed across the spectrum, as well as internal medicine. So those should be your primary focuses for who you're going to need, how are you going to call them in. The things you want to think about is, with these services, how many can you perform? What do you normally have on staff? How many of these specialists do you have at your facility or in your organization? How many are on site routinely? Do you have physicians that just come in a couple days a week? Do you have surgeons that work out of a different office but then come in and perform surgeries at your facility a day or two out of the week? Can you transport people out to other facilities that maybe perform these different surgeries if you don't do them at your facility? But think about, how will you contact these physicians? How will you get these subject matter experts, these members of your care team, to your facility? And the big question, and sometimes the elephant in the room, is how often do your physicians participate in your drills and exercises? How often do they come in and sit at the planning committee table? How often do you see them working with the overall team to move patients from the parking lot to the ED, to the OR, through recovery, to a room? How involved are they in that process? And I understand, I won't say, the world is all easy and rainbows and you'll just be able to get everybody at the table that you need to. But if you are responsible for planning at your facility, absolutely try to target these groups and get them involved in that process to see both sides of things. Don't take anything for granted, and make sure that you can involve them and bring them in as you need. Consider as well, your credentialing and volunteer staff. If someone shows up at the hospital and they flash an ID and they say, hey, I'm a physician for such and such agency, I can't get to my hospital because the road's flooded or the earthquake dropped the overpass, whatever the case may be, figure out how you're going to integrate them into your care team. Can you? Do you have credentialing policies in place? Make sure this is documented, laid out. So think about your group that's at the hospital, your employees, your normal contract physicians, but then also how you would bring other people in to help out really in those early hours to maybe first day or two of the event. So now that we've talked about all the planning considerations, let's kind of go down this road a little bit and talk about some considerations for your plan. And number one, again, another elephant in the room, is that not everybody's going to follow your plan. It could be very well written. It could be the best plan that you think you've ever seen. People a lot of times are going to blaze their own trail. And generally speaking, it's because they're going to follow their training or lack thereof. If you put people in a situation where they don't have training to follow and they just have to go with their gut instinct, they're going to go with what they think is the best way to handle it at the time. They're going to react much more in a fight, flight, or freeze type response and just go, oh man, this is happening. I need to do this because I think that's the best option. We want people to fall back to their training. So that means doing this a number of times. So it's repetitious, it's muscle memory. An event happens, we identify it as a disaster, a mass casualty surge, and now we're getting out there doing what we need to do. Dependent upon the disaster, you're either going to know immediately something's going on. If you experience an earthquake in your community, more than likely everybody is fairly aware of that when it happens. But a tornado could hit at an opposite end of your metro area and you not be aware of the damage until your first casualties start to arrive or social media starts spinning up. So think about how you're going to get notified of these events. And keep in mind, for man-made disasters like an active shooter, this is very, very true, that you may not have an initial notification until somebody shows up. You start seeing social media, start seeing news reports. So think about how you would manage that if your first notification was a patient to arrive at the facility from a larger event. How would you identify it was an event, and then how would you begin spinning up your surge team? The initial casualty numbers being often exaggerated. Again, I'll give you a personal story with this. One of the events that I dealt with fairly early in my career was a tornado that hit a fairly rural area close to one of my hospitals in my system on Christmas Eve. So this was the night of December 23rd. Very large tornado, long track tornado, hit several communities, came through, did a lot of damage. We started getting patients in. There was pretty good communication with the field and first responders, but we couldn't get an accurate patient count. And one of the first things we heard was, you've got about 200 patients coming your way. Now, my response in the command center was, why are they sending all of them here? There's other hospitals, and this was a fairly small facility. By the time we actually got accurate communication with the team down there that was handling, said, no, we've got about 200 people in the parking lot here at a Walmart. They're mostly minor acuity. We're doing some assessments on scene. Majority of the patients that you're going to see have already been transported, but we're still doing search and rescue operations. So 200 turned into about 14 or 15, if I remember correctly, fairly quickly. So you have to be able to manage those communications to try to get an accurate patient count. But then again, remember, going back to that, how many patients arrived in the first hour is probably a good indicator of what you're going to get over time. Now, again, we've said this multiple times, but it bears repeating. Make sure you're planning for the majority of those patients to just show up. All right, they're going to get in private vehicles. They're going to show up at the hospital. Think about how involved your security team is with this. How much does your EOP kind of take into account an influx of vehicles that will more than likely be rapidly pulled up to the ambulance bay doors, the emergency department entrance, the front entrance of the hospital, and then more or less abandoned, right? As people get out, they try to get the people they've rescued or their loved one, or maybe even themselves, into the hospital. Is your security team prepared to manage that? If you don't have a security team, if you're at a critical access hospital or something like that, how are you going to manage that? How are you going to manage the influx of vehicles, parking? So you have to make some considerations for that, where you might move them or how you might direct traffic flow once you identify there's been an event. When your walking wounded show up, whether it's initially or over those first 2 hours, make sure you have a reception plan in place so that you're not just taking those minor casualties back to any open ED room, to hallway beds, anything of that nature. Make sure you're identifying areas that you can take them and keep some of your rooms and your other resources freed up. You don't want to tie up all your existing space by just grabbing those first people that come in and taking them back. Another thing to consider with this, and this is again another thing that came out of the Las Vegas shooting, a lot of your current ED patients that are in the waiting room, they may leave depending on their situation and how sick they are or aren't. They may decide, large number of people coming in means I've got to wait more, so they may decide to go. And you just kind of need to be aware of that. So if you're going and trying to track down patients later, they may just decide, hey, I'm heading out, or I'm going to a different facility. How that's going to work out for them, who knows? But they may do that, so be mindful. Another thing to consider with casualties being triaged or not, obviously, if they've left on their own or if they've been brought in by personal vehicle, they're not going to be triaged. If they were exposed to any chemical contaminant, again, a man-made event, if you think terrorism attack, that there may be chemical, biological impacts of it, they're not going to be decontaminated. They may not have received any medical aid. So make sure your staff are aware of how to identify chemical contamination, what to do with that patient if they find something on them. Patient was to show up with powder or smelled strongly of a chemical, you wouldn't just walk them into the ED regardless of their injury, right? They got to be decontaminated. So you've got to be mindful and looking out for that stuff. Even in a natural disaster, things may occur. We don't know, did that person work at a chemical plant with highly toxic chemicals and a tank ruptured, and now you've got multiple people that are covered in a chemical contaminant? Those are things you have to look for. Special needs casualties, we talked about this earlier with the HVA and identifying your vulnerable populations. You have to think about people with existing conditions, could be physical, sensory, any mental health issues, cognitive disabilities, non-English speakers. All these different types of groups may come in the MCI, so we need to be prepared for how we're going to manage them. As unfortunate as this is to say, And I think our goal is always to try to save everybody as healthcare providers and those of us who work in, I think, emergency management, first responders in general. We want to try to save everybody. But in a disaster, we always go back to that saying of, do the greatest good for the greatest number. And keep in mind, you're not going to be able to care for all those patients, especially not immediately. So this is why disaster triage is so important, to identify those patients and then kind of separate them out. Your facility may be damaged. If you have an earthquake or tornado, hurricane, how will you manage your own internal patients? What about staff that may be injured? Do you even still have the capacity that you did before? Do you have an emergency department? Do you have an OR? Do you have an ICU? Do you have equipment that now you suddenly can't access? You may have to say, we're no longer fit to provide any level of care, and our building is so damaged, we have to move people out. We need to evacuate. So do you actually have a plan for that? Do you have that plan that says, okay, patients may be showing up, but we now have to evacuate our facility? How does that get communicated to the larger community? How do you implement that process? How do you switch over from patient care on a normal day to now an event's happened and people are starting to show up, but we've identified the building's not safe, so now we have to evacuate everybody out? How are you going to move them? Where are you going to take them? Do you have an alternate care site established? How are you going to move them, especially with other things tied up? You don't have ambulances, you don't have buses maybe, so the evacuation planning is something that absolutely needs to be considered in your mass casualty incident planning for natural disasters. Now, the different resources out there to kind of help you with some of this, there's several. Most of you are probably familiar with these documents, but National Response Framework document you can download for free online, and we affectionately call it the NERF, even though we're not supposed to use acronyms, plain language, right? But it's outline of plans, your scenarios, different education and planning tools for being part of that overall community approach. National Incident Management System, if you're implementing the Hospital Incident Command System, plain language, working with the community, whether through a healthcare coalition or your community partners, then you're already pretty much using NIMS. But it's just that consistent way of kind of doing things across the government, the private sector, working with non-governmental organizations. How do we work with volunteer organizations to get resources, all these different things. And it's supposed to be flexible, right? So it's a guideline that we use, but it's supposed to kind of make everything consistent across the board. The national security strategy basically is just, it's kind of the government plan to secure the country. How do we combat terrorism? How do we promote resilience? And that can be a good supporting document for your man-made emergencies, especially your man-made disasters, excuse me. Helps you kind of build that side of it out. And then Presidential Policy Directive 8 or PPD 8, the national preparedness goal is basically just, it's kind of aimed at strengthening our overall security and resilience of the U.S. And it's that systemic preparation basically for all the threats that we may face. So that's everything from terrorism, cyber attacks, pandemics, catastrophic natural disasters, and how we want to try to prepare across the board as a country to meet those. Another thing to look at too is community resources. Talk to the people in your community and involve them. Local law enforcement, EMS, fire, public health. Get with these groups, make sure you know them prior to the event and that you can bring them in and include them on things. Now, the next one, this CDC Mass Casualty Predictor Model, that's pretty much what we used earlier, where we're looking at the, first hour casualties times 2, and this fleshes it out a little bit more. It's definitely a document that's worth the read to kind of help you figure out, based on the disaster, what might we need, what might we use, and then what is this going to look like for us. Health and Human Services documents, so those mass casualty effects, mass incidents, med-surg capacity and capability are all, again, really good guidance documents to help you develop that plan. So if you don't have a strong surge plan, or maybe COVID-19 is making you kind of rethink what you have and you're looking at different things, maybe because we're getting ready to get into hurricane season, you're reviewing everything. These are some documents you can download and kind of review. And I really like to do kind of a spreadsheet comparison. I look at the things that they say to have, and then I want to go and try to find them in my plan. Is this addressed? And if it is it good enough? Do I have that legal kind of line in there that I go, okay, if Joint Commission or a regulatory agency shows up, I can say, well, here's where it's addressed, but is it an actual functional plan? Is it actually something that tells people what to do and what they need to do? Caitlin mentioned this at the beginning, but I'll show you if you're looking at my camera. This no notice incidents, Ask for Tracy tip sheet about the Las Vegas incident. There's tons of really good pieces in there that kind of help you look at a lot of these things and document this stuff, but there's these little tidbits of things that you don't always think about. And I know that even as I read them now after doing this for several years, little things like this one. Pop the heads up on gurneys so patients are not placed backwards. So when you think about running out with your extra stretchers or gurneys and placing patients on them out of private vehicles or from ambulances so they can turn around and go get more patients, whatever it is, when you bring them in, that's a time-saving effort. So as you're rolling them out, make sure that head is popped up so you put them on the stretcher the right way and move the patient around. It's little things like that that are often overlooked in the planning process. So as much as I think we all wish we could learn these things and talk about them without them actually happening, it's best if we can use what's available, learn from other people that have experienced it, and then implement these things in our own plan. So I highly, highly encourage you to look at the available resources out there. So to kind of start wrapping this up and bring this to a conclusion and make sure I leave some time for questions, it's always good to look at those lessons learned, right? And we say this a lot. It's like, oh, lessons learned. We learned this, we learned that. A lot of times we really fail to learn any lessons at all. We identify a problem, but most of us don't actually take any action steps to fix it. So the all hazards approach, that whole community approach, is something that we need to get a lot better at implementing it. And this is my opinion, but we don't always look at all the hazards for their similarities. We still look at a lot of things differently. So even as we've talked through this and identified, well, maybe we have this injury in this situation, maybe we have this injury in that situation, maybe we need this doc for this one or this resource, we still need to look at what hazards are relevant to our community. So that doesn't mean all hazards. If you don't live next to a volcano, you don't need to plan for one, right? So look at the similarities of them and then kind of determine, okay, if we get a surge of patients, regardless of the situation, how are we going to identify and triage those patients? How are we going to manage them through the flow of the event, from the time they arrive all the way till discharge? How are we going to manage that and track that? What resources do we need? How much do we work with the whole community? Do we communicate with EMS and public health and law enforcement and fire? When's the last time you talked to FBI or any of these other groups that may have insight on terrorism? Think outside the box with these groups that you want to engage and bring in. Planning, training, and drilling. Let me say this with planning. I look at plans, I say the 3 Ps all the time is kind of my thing that I tell everybody. It's the plan, the process, and the people. If the plan is well written and it's a functional EOP and everybody gets it, or it's an annex, whatever the case is, well written plan, good process, bullet pointed, laid out just like you need to do it, vetted, best practice, but the people aren't trained and they're not drilled and exercised on how to implement it, everything that's on paper is useless. And you can back that up. If you have a good plan but a bad process, the people will never be able to implement it. If the plan is poorly written or maybe doesn't exist, it'll never happen. It'll never get off the ground and people will just continue to do whatever they feel they need to do. So plan, train, and drill. Train as often as you can. when you drill and you exercise, document it. Look for the gaps, find your opportunities for improvement, document those opportunities for improvement, and then fix them. Make an improvement plan, and then actually put work to this and identify it. You don't want something to happen and say, yeah, we knew about that, but well, what can you do? Coordinated response, again, goes back to that whole community approach. Who are you working with? Who are you talking to? How does what they're going to do in the field, or how EMS is going to transport patients to the hospital, how does that impact you? But also, how do your practices impact them? If you can't rapidly accept patients, you tie up an ambulance and an EMS crew, they can't go out into the field to get more victims. So think about how quickly you're doing things and who else you might be impacting as well. Fluidity. Years ago, I was told by somebody the phrase semper gumby, okay? Always flexible. The situation is going to constantly change. You have to be able to constantly change with it. It's one of the reasons that planning and drilling and exercise and training and all these things can be tricky. You want to work within that framework, you want to work within that guideline, but you also have to be able to change when the situation demands it. And that requires situational awareness. At all times, you have to be aware of what's going on. So for those of you that are familiar with Incident Command System or Hospital Incident Command System, this is why it's so critical. You have to have that overall operating picture of what's going on. Communication and information coming in, communication and information going out. Needs to be streamlined. We need to be using all those good Hicks and ICS principles, span of control, unity of command, management by objective. Use that to run this event and make sure that everybody is doing what they need to do, where they need to be doing it. We're tracking resources, and we're talking to the whole community and getting everybody involved. With communications, the biggest thing that we always say about communications is that it's a problem. All right, it's a problem on every drill, every exercise, every event. And we test them, but we don't always test them. All right, so don't get focused on just your equipment. Well, we've got cell phones, we've got satellite phones, we've got email, we have all this stuff. That's great, but you need to test it, but you also need to know how to communicate the proper information. Who needs to be receiving the information? Who needs to be sending it out? I see Miss Candy Waylock is on in the webinar, and she'll tell you for PIOs that getting that information out and getting it to the right source is critical. So if you have anybody who is functioning as a public information officer, a liaison officer in your command center, they've got to be trained, they've got to be educated, and they've got to know how this stuff works so that we can get what we need, and then we can get the rest out to the people that need it or to the community. Don't forget about your internal people as well. They need communication. Associates or employees want to know what's going on. Patients, families, and visitors are going to want to know what's going on. So account for all those groups. And last, again, really remember that what we're trying to accomplish with all of this is taking care of people, right? We are trying to do the greatest good for the greatest number of human beings that are in our communities. So everything we do, from writing the plan to having our committee meetings to planning this stuff, writing it out, testing, exercising, this is all for and all about trying to do the best we can for the people that are around us in our communities. So with that, I will thank you all very, very much for participating. And then I guess,
Thanks
Caitlin,
so much,
I'll turn it back over to you and see if we have any
Okay, everyone,
questions.
if you've got any questions, if you will, go ahead and type those in the chat box. John Corfield from Orlando Health asks, do you have any suggestions or recommendations on ways to support foreign patients who may not speak English as a primary language and who don't understand the U.S. healthcare system?
Okay, so I can give you some experience from this situation for myself, and the obvious short answer is interpreters or trying to identify maybe different cultures, different languages that would be in your community. So, work with your local government agencies to determine what type of populations you have, but also identify the events that may bring people from other countries with other languages into your community. Here in Memphis, we have Elvis Week every year. And one of the things that we have seen is a large Filipino population tends to come in for that. And so we have tried to make sure that we have interpreters or maybe little education documents in multiple languages to try to explain those basics. It is very, very difficult to plan for every single eventuality. So again, thinking outside of the box, don't necessarily be afraid to rely on something like Google Translate. If you've got your phone and you can say a phrase and it repeats it back, obviously you have to be able to identify what language they're speaking. So if you don't know, that can make things a little bit more complex. But to try to not make it too long of an answer, really try to figure out the different populations. And then if you're an emergency manager, do some research and identify maybe some of the cultural differences that you could anticipate they would have concerns about or questions about, and try to just have some information prepped in advance.
Okay. From Jason Fox, we have any thoughts on communications technology within the hospital and between the hospital and external stakeholders such as local EOCs, nearby hospitals, etc.?
So what we have used in the past with a fairly decent success is any interconnected system. So we had what was called HERTS, which is Hospital Resource Tracking System, and then THON, which is Tennessee Health Alert Network, that allowed us to communicate with other groups, public health, local and county EMA, and then also the other hospitals in our region, so we could coordinate resource requests and things like that with the EOC. Another one that is good is radios, 800 megahertz radios that you can communicate out, get dedicated channels for. Cell phones that are dedicated specifically to disasters can be helpful. Don't ever overlook a satellite radio or a ham radio. Ham radio operators are often overlooked, and a lot of people forget about them because there's not just a ton of them out there anymore. It's one of those things that we really need to kind of start bringing back and focus on, especially for natural disasters. So reach out to those communities, but bring it up and see what would work best for your region. Keep in mind with communications, if you're in an area where cell service may be spotty, radio communications sometimes break down, you may need things like satellite phones to work.
Okay, and we have a comment from Chris Perrin. FYI, there is a good series of articles on hospital triage, concerns, and strategies by Kevin Menez, AD physician on duty following Las Vegas shooting and Emergency Physicians Monthly. Joshua Angle provided a link to a case study for everyone to share. And it looks like I've got one more question coming in. Chuck, do you have an opinion on spontaneous or emergent volunteers presenting to the hospital in times of disaster?
I have a lot of opinions. No, I say that jokingly, but volunteers are great, but you have to look at it kind of the same way as you do with spontaneous donations that are sometimes unsolicited. You have to account for the fact that people are probably going to show up. And I joke about this in classes a lot of times where I go back to, if any of you have ever seen the movie Independence Day, when Cousin Eddie, Randy Quaid, shows up and he says, "I can fly, I'm a pilot." And I always go, are they going to really put Cousin Eddie in a jet plane? And sure enough, they did. Think about how you're going to utilize those volunteers, especially if you can't credential them. If somebody shows up and says, well, hey, I'm a nurse, I'm a doctor, I can help. How do you verify that if you can't verify it? I think people can still help. There's a lot of people that may come in, can they help move equipment? Can they pass out water or food? Could they maybe just sit with staff and help keep an eye on your walking wounded? Can they help carry supplies out? Can they help unload a truck? There's implications for that with those volunteers that you may have to consider. If you put them in any situation that's too dangerous and they get injured, that could be a problem. The way I always recommend everybody do this is a lot of pre-planning, working with public health, working with EMA to get CERT volunteers, Red Cross volunteers, work with some of those organizations. Team Rubicon is another really good volunteer organization that you can kind of look at some of their best practices for how they manage their volunteers, and you may be able to implement some of those practices for yourself at your facility.
Okay, we've got one more. What is the best way to utilize ham radio for disasters, hospital-centered?
So what we have always done in the past, and again, I go to my personal experience with it, is that we had a coordinator for our region that worked with all the different ham radio operators. We had a ham radio and antenna set up at each of our facilities throughout the region, and we brought them in on every drill and every exercise, and they would fill out an ESF-8 form with information. They were integrated into our command center. They would send information up and down the chain. They would talk to the EOC. They would talk to other hospitals to share information. So they got the practice they needed. We always were able to identify if there was any issues with equipment during the event or drills or exercises. But it was a really good partnership, and actually as a byproduct, a lot of people throughout the hospital system then became interested in how to utilize ham radio for disasters, and they went and got certified. So find people in your community that do it and just bring them in. They'll guide you on a lot of it, but make sure they're involved and utilize.
Okay, are there any more questions? While we're waiting on anyone to type, I'm going to point out a couple of things to you again. The bottom left corner of your screen is the link to that feedback survey. Please go and give us some feedback. Let us know what you liked. It is a 5-star scoring system. Think just like a hotel or a restaurant. 1 is terrible. 5 is wonderful. 2, 3, and 4 are somewhere in between. The remainder of the offerings for the month of June are available at cdp.dhs.gov/VILT. That's also in the bottom left-hand corner of your screen. The bottom right, you have the PDF of the presentation, Chuck Lane's bio, and some additional PDFs on the Las Vegas articles and some additional things that we discussed today. It does not look like we have any more questions. Again, I thank you for, oh, wait, we may have one more. Hold on. John, yes, if you don't mind, I'm going to put that in the group chat and they can go. Everyone can visit that link. So John Corfield from Orlando Health says, is it possible to share a link with the group on a model our healthcare system uses to identify and support foreign patients? If so, please find it here. And he shared a link with me. I'm going to share that with everyone else. This is a shared with the group by John Corfield from Orlando Health. And feel free to go and check that out. You will receive an email from me with the link to the feedback survey in that. Again, we do want your feedback. It helps us determine what we're going to be doing in the future. So if there are no more questions, I'm going to do a final call for questions. Okay, looks like